This program is brought to you by Emory University.
Good morning, everyone. Welcome to Cardiovascular Grand Rounds. Before we start, two announcements. One, to Emory Clinic physicians, look out for a nice email coming from me today with reminders about ICD-10 and about our SOUP metrics, which all kick in later this week. The second announcement is very important. It's Gina Lumberg has asked us to point out that the Reward Your Heart program is going on Thursday night, this week, Thursday night from 6 to 8:30 p.m. And that's it's a evening of sort of information about heart healthy indulgence, and from the women's heart group. They will have hors d'oeuvres, soothing teas, aromatherapy, hand massage, that'd be good for all you cath guys, wine tasting, specialty olive oils, and door prizes, and Jennifer Mears is going to speak about the benefits of changing healthcare, and it is free for all Emory fellows and faculty. So think about coming. We'll send an email out with that. And with that, we'll move on to our presentation today, which is a three-parter, or three people working together on this. Tanveer Rab, Neal, Dickert, and Mike McDaniel are all going to join in the presentation today. As you can see, they all participated in this, position paper about the algorithms for treating patients after resuscitated cardiac arrest, and we all know this can be a very challenging situation, and so now they've got it all worked out. There are no gray areas. It's really straightforward, and we know exactly what to do. And Tanveer is going to start us off, I guess.
Thank you. Good morning. This subject did not have any organized effort or presentations for many years, and the American College of Cardiology, particularly the Interventional Council, was concerned that there's no organized document to at least address this issue, that when we are called in the middle of the night, or otherwise, for a patient who's comatose after cardiac arrest, what to do and who to take to the cath lab. And the guidelines were very vague about this, and to be honest with you, there's not a lot of trials or published data, the small studies. And so the task was given to organize a writing group. Fortunately, we took early career faculty like Mike and Neal, and prepared other people in the country like Tim Henry and Carl Kern, who have enormous experience in this area, and people from New York and the West Coast, to try to get a blend of what our thinking was. We reviewed about 108 papers on this subject, and it took us about 15 months just to draft this document. So the title is Cardiac Arrest, a Treatment Algorithm for Emergent Invasive Cardiac Procedures in a Resuscitated Comatose Patient. We have no disclosures for this presentation. So out-of-hospital cardiac arrest, and there's some improvement. In 2013, there was more than 500,000 people who died after out-of-hospital cardiac arrest. The numbers are down a little at 350,000. And neurologically favorable survival has improved. But despite these advances, mortality remains high. And it's not putting a stent in a coronary that makes them survive, but the death occurs because of brain death or multi-organ failure due to prolonged hypoxemia and microcirculatory hyperperfusion, the acidosis that arrest ensues in the body, with only 5 to 15% of patients surviving to discharge. Why this paper? This was to identify patients with unfavorable features in whom emergent cath and PCI would offer very little benefit after cardiac arrest. This was very important for the vast majority of the interventionists who really felt they were taking people who were really dead to the cath lab, and really there was no benefit of taking them to the cath lab, and these were going to die regardless. So we had to identify a group which would not benefit. To provide guidance to clinicians regarding the acute management of cardiac arrest in patients without ST elevations. 3 out of 4 patients cardiac arrest do not have ST elevation electrocardiogram, and this group has been ignored in terms of the stratification to be taken to the cardiac cath lab, where they may have benefit. To respond to the knee-jerk response on the part of many EERs to activate the cath lab after cardiac arrest, even though in core measures the metric of door-to-balloon time is excluded. So to take these people rapidly to cath lab has never been recommended. I think many times when the ER calls, your cath lab is activated, and the next thing you have is a patient who is comatose and near dead in the cath lab and trying to do a procedure which may not be justified in all cases. But the important metric is the door-to-balloon metric is not measured. And to address the increasing concerns that public reporting and pay for performance of PCI mortality promotes risk-adverse behavior in the care of patients with cardiac arrest. And I can tell you, nationally, the ACC has documentation that patients are not being provided care, and our citizenry is not getting benefit because of the public reporting issues associated with this area. So we create this algorithm. We'll walk through that. It does look a little complicated. We'll go through each step. This took a lot of time, a lot of effort, a lot of months just to come together to this particular version of the algorithm which we published. The first thing is this is about out-of-hospital cardiac arrest patients who have achieved return of spontaneous circulation but still remain comatose. Within 10 minutes of hospital arrival, they must get a 12-lead cardiogram to identify those patients who may benefit from emergent angiography. This is a guideline recommendation that early risk stratification electrocardiogram is essential. A 12-lead must be obtained as a class 1 recommendation within 10 minutes of the arrival of the patient to your facility. The next is that everybody must be cooled. Cooled before you do anything major, like think about taking them to the cath lab, you must start cooling. For every 30 minutes lost, the mortality increases exponentially. So they must be cooled. Induce targeted temperature management with mild therapeutic hypothermia to limit tissue injury after cardiac arrest. So this again is a recommendation, it's a class 1 recommendation that therapeutic hypothermia should be started as soon as possible in comatose patients STEMI and out-of-hospital cardiac arrest, particularly in those who have VFib or VT arrest or the shockable rhythm arrest. So this is an older study from 2002 where patients were cooled, had a better neurological outcome. If you can compare the two, 39 versus 55, and the mortality decreased in those who were cooled versus those who were not cooled. The temperature at that time that had the best result was at 33 degrees, with those at that temperature had a better neurological outcome and has less deaths just being cooled. Lately, mild therapeutic hypothermia at 36 degrees have shown to be of similar benefit to the ones who were cooled at 33 degrees. So most people, or most patients are cooled at 36 degrees now. But that's not the gist of the paper. We'll go on and talk about what to do next. So if you have ST segment elevation electrocardiogram, you still activate the cath lab. Activate the cath team to come on in. But again, you should take time to evaluate the patient and consider the survival benefit risk ratio, even if multiple unfavorable resuscitation features are present. And if those who are deemed suitable can go through emergency angiography, coronary anatomy can be defined, and if there's a coronary lesion that can be treated, that should be treated with a stenting procedure. At the same time, you could do a LV function assessment, and if they need mechanical support, you can go on and do that. But again, the important feature is that you should take a little time to assess these patients. The knee-jerk response of trying to change the door-to-balloon time does not apply to these patients, and time must be taken to evaluate them before you take them to the cath lab. The next segment addresses the issue that the guidelines state that immediate angiography and PCI, when indicated, should be performed resuscitated out-of-hospital cardiac arrest patients with initial electrocardiogram, so it shows a STEMI. You should focus on the word when indicated. That's why they never addressed the issue of door-to-balloon time. The door-to-balloon time metric was not mentioned in this statement. Now, our paper showed, we've looked through approximately 28 studies, that combining target temperature management and early coronary angiography in resuscitated but comatose patients STEMI and electrocardiogram, those who survived to discharge, they survived discharge 60%, and neurological outcome was good, and those who had hypothermia, early angiography, and probably intervention, the neurological outcome and survival was a good neurological outcome was 86%. The next segment deals with the no ST segment elevation electrocardiogram, a segment that has not been addressed, and Michael will talk about that.
Thanks. We're going to swap it up a little bit to keep it interesting. So the more controversial group is this group here, the patients without ST elevation on the EKG. And this is probably the more important group because it's the majority of the patients that we're going to see. 75% of the out-of-hospital cardiac arrests do not have ST elevations on the EKG. And the important thing is the guidelines have not addressed this group. So because of that, because of the paucity of data, it's been a more heterogeneous group with more heterogeneous treatments. And so we felt it was important to address. This is, I think, the key finding or the key slide when it comes to management of patients without ST elevations on a cardiogram. And what's the take home is the majority have severe CAD, and a lot of them will have culprit lesions. This is a summary of multiple different trials that look at the angiographic findings on patients who go to cath after out-of-hospital cardiac arrest without ST elevations. And the takeaway of multiple trials, and all these are observational studies, is that about a third, about 30% will have a culprit lesion when you go to the cath lab, and the majority of these culprit lesions are acute occlusions, similar to what you would see with an ST elevation MI. And there's probably benefit in both the identification as well as treatment and revascularization of patients with culprit lesions, especially acute occlusions. Another large minority will have a severe CAD, severe obstructive coronary disease, that could be important to identify. One, as it probably defines and contributed to the etiology of the cardiac arrest, but two, in selected patients, particularly those with ongoing refractory cardiogenic shock, despite treatment of the resuscitative measures as well as hemodynamic support, that in selected patients with severe CAD may benefit or derive a revascularization benefit to prevent or to treat the shock. And it's actually, though, a minority of patients that don't have severe CAD. And so this really sets up the rationale to treat a lot of the patients with out-of-hospital cardiac arrest without ST elevations similar to those with ST elevations. The other thing is that the observational data suggests that those that do get angiography do better. This is probably the largest study to look at that. The International Cardiac Arrest Database recently published, and the takeaway is even without ST elevations, those that get early coronary angiography have much higher survival than those that do not get early angiography. Now, this is observational, and it's completely confounded and does not prove causation. All it is an association, and obviously patients are treated differently here than they are treated here. But the same finding has been seen over and over again. If you look at probably the totality of the data, a meta-analysis of 15 of these observational trials, again, all confounded because these aren't randomized. But if you look at the totality of data, both in ST elevation as well as non-ST elevation MI and out-of-hospital cardiac arrest, that there is a higher survival in those that go for early angiography compared to those who do not get early angiography. Again, a lot of confounders here. It's all observational data, but all we can say is the association is higher with better survival with early angiography. So as such, the thought is that many of these patients should be treated in a similar manner as those to ST elevation, with the caveat to act. A, to assess for unfavorable resuscitation features in which angiography may not be beneficial. Two, C, consult interventional cardiology. These are patients that before activation probably a discussion is warranted. And that's one of the key findings and key things that we wanted to get out there, is that there's such a heterogeneous group that it's good to discuss the case and individualize your care on each of these patients on a case-by-case basis. There may be some patients that you get labs first. There may be some cases you get an echo first. You may get send some to a CT scan of the head or PE protocol to look for other sources. But once you've assessed this, then otherwise the majority you want to T-transport to the catheterization lab, because many of these patients can, if suitable, derive the same benefits that this group with ST elevations, for which is a class 1 indication. In that there is early angiography can define the anatomy, lead to culprit lesion revascularization, PCI perhaps in severe CAD with ongoing cardiogenic shock. It's an opportunity to assess the LV function in a rapid manner, provide hemodynamic support with balloon pumps, Impella, and ECMO when and if needed. So the majority of patients probably derive some of the same benefits as those with ST elevation. The key thing, though, is to talk about those who may not derive a benefit. And Tanveer is going to walk through some of these patients with unfavorable resuscitation features.
Before I go on to this segment, it's important to note the there's not enough data out there. These are based on small studies. The N is, or the number of patients these observations are made was small, but that's the only thing we have out there. So in patient multiple unfavorable resuscitated features that we looked at, these issues: unwitnessed arrest, initial rhythm being a non-VF or PA or asystole, which is an unfavorable feature, no bystander CPR, greater than 30 minutes to return of spontaneous circulation, ongoing CPR, a pH of less than 7.2, lactate of greater than 7, age greater than 85, end-stage renal disease. Other issues like traumatic arrest, aortic dissection, etc., drowning are obviously naturally excluded. So let's walk through each one of them. Unwitnessed arrest is associated with poor outcomes. Okay, so this is again from the CARES registry of over 25,000 patients, that those who had unwitnessed arrest don't know how much the downtime was. Really, the survival was extremely, extremely low, and these patients will not benefit from going to the cath lab. So those who survival discharge and unwitnessed, about 6.4% versus 13.5% of those who were witnessed. It's important to note that 79 studies involving 142,000 patients, 53%, half of these were witnessed arrests. What about non-VF VT as initial rhythm? Those with asystole and pulseless electrical activity, the survival rate is poor compared with those with a shockable rhythm such as VT and VF. No bystander CPR associated with poor survival. 79 studies, again, over 140,000 patients. 53% were witnessed, but only 1/3 or 16% got CPR. This is a dismal rate. As you know, the Institute of Medicine this year, based on the CARES data, has recommended very aggressive education and implementation of CPR protocols all over this country. And in Paris, for example, 90% of those patients who are witness arrest get CPR, compared to only 16% in this country. So if you don't get any CPR, survival discharge 3.9%, whereas if you get CPR, it's 16%. This is from Carl Kern's group, that those who did not get any bystander CPR, again, in that particular, in Arizona, their survival was 5.2, conventional CPR was 7.8, and continuous CPR was 13.3%, and this led to the change in the ACLS guidelines about continuous CPR to improve your survival. Prolonged, I don't know why this comes, greater than 30 minutes of return of spontaneous circulation associated with poor survival. So up to 0 to 15 minutes, your chance of survival is very good, but if you cross the 30-minute margin, your survival goes down. Survival to hospital discharge goes down considerably, but the number was very small. Again, prolonged CPR, again, 30 minutes associated with poor outcomes. The longer you take, your neurological survival and the modified Rankin score of good neurological function really deteriorates over time. However, 90% of patients with good neurological recovery are those who have achieved return of spontaneous circulation within 16 minutes of CPR. So up to 16 minutes of CPR is good for you. And the Paris group just put out some data that even up to 20 minutes may be good in terms of good neurological survival. Now, this is a smaller study, a pH of less than 7.2 associated with worse neurological outcomes. This is cerebral performance category, which is poor is 3 to 5, good is 1 to 2. So if your pH is less than 7.2, the bad neurological outcome is in the majority, whereas the pH of more than 7.2, the better chance that you will have a good neurological recovery. But again, the number in this study were very small. A pH of 6.9, for example, is not recoverable neurologic function. And that was, I didn't put that up here, but that came from a CHEER study out of Australia. Lactate levels greater than 7 associated with poor survival. This is evidence of tissue hypoperfusion and microcirculatory failure. This is from the Paris ProCat study with about 435 patients. Lactate less than 2, there's a 42% survival, but if there's more than 7, the survival is about 13%. Advanced age associated with low survival rates is also always very controversial, but from 6 interventional cardiology centers in the United States, survival discharge of 46% of those between the ages 18 to 75, and greater than 75 was only 33%. Advanced age greater than 85, again associated with poor survival, is from a Danish registry. 1,000 patients, mean age of 85, 25% could be resuscitated, but the death was 81% in 1 month. Those less than 80, the resuscitation first resulted in survival of 40%, but again, in 1 month, the mortality was less in this group compared to the greater than 85 group. What about renal failure? This is a slide from the American Heart Association. The cardiac arrest occurs in 26.3% of patients with end-stage renal disease on hemodialysis. And if you have had a cardiac arrest, at 1 year, survival is about 10%. As a study from the community facility in Seattle, and those outpatients who had sustained VTVF, those who had PEA or asystole, the survival at 1 year was 5%. Those with shockable rhythm was about 19%. These patients, we feel, are a group that are unlikely to benefit from coronary intervention. They should be assessed. It's not just one factor that you should look at, but they should be assessed for multiple of these unfavorable resuscitation features, and the likelihood of them benefiting from a trip to the cath lab and getting a stent and surviving is poor, and poor because of poor neurological outcome. They're less likely to benefit from coronary intervention, and individualized care and consultation by interventional cardiology and assessment of these patients by us is very strongly recommended. Neal?
You need me to back up? So I'm going to solve all the ethical problems associated with these issues. Clearly these are situations where ethical challenges are unavoidable. We have situations where there's very high mortality, major morbidity, need for very rapid action so you don't have the kind of time to think through these situations that you might in many others, and pretty complex risk-benefit trade-offs, right? This is a situation where obviously one of the not unlikely outcomes is survival with horrendous neurologic status, right? So that is it's one of those challenging situations where what we're doing, which may prolong our ability to support other organs, may put a patient in a position that from some people's perspective is one of those kinds of outcomes that can be worse than death. And it's made more complicated by the inability to interact with the patient because they're comatose, and often the inability to interact with surrogates when there are significant time pressures. I just want to highlight from this group the discussions that we've had about what I think are really three key issues in trying to manage these unavoidable ethical challenges. So first, there's clearly an ethical imperative to do research. Often we don't talk about the fact that clinical research is really something that is an ethically important obligation for us to do, and I think this is one of those areas where it's abundantly clear. The evidence base for many of these decisions is incredibly weak. It's limited to observational data, which is heavily confounded. And we really have insufficient trial volume to date with regard to cardiac arrest in general. We've seen the way, for example, that trials looking at therapeutic hypothermia have really had an important impact on how we care for these patients, and the fact that subsequent trials continue to inform practice. Not to state that it's now clear what we should be doing with regard to therapeutic hypothermia, because in some ways further trials have made it less clear. But it's an important example of the way that trials can be done in these circumstances. They should be done in these circumstances, and they can have a big impact on how we deliver care. And I think as many people are not aware, and you all have, not to beat my own drum too long, but I've talked about it before in this context and others. It's important to recognize there are regulations that do permit these kinds of trials to be done, and they can have an important impact. So second, we have to confront determinations of futility, right? This is not something that we excel at as a population trying to sort out how we make these kinds of determinations, but all of us know that we do these things all the time. We have to do them and we should do them, right? But the important, I think, upshot from Tanveer, from the data that Tanveer presented, is that clearly these assessments require clinical judgment and the integration of data with important value judgments. The potential for neurologic impairment really does complicate the risk-benefit determination. It's not really an issue of does this offer, it's not really just a simple issue of whether this offers a chance for survival. You have a lot of important issues to take into account with regard to neurologic status. The other thing I think it's really important in contextualizing these data, and again, it's obvious, but determinations of benefit can't just be based on relative benefit, right? Or the fact that the prognosis is just poor, right? There's a huge difference in a therapy that offers a chance to move from a 10% chance of a good outcome to a 20% chance of an outcome compared to one that goes from 1 to 2, right? It's the same relative benefit. At the same time, whether or not one would be considered futile, and depending on the patient's context, may be very different from the other. Probably most importantly, particularly given the fact that these are often highly sensitive issues, this is an area where there's clearly a need for transparent discussion, both within the profession and with the public about these kinds of determinations. Finally, I think one of the important parts about this sort of ACT process of taking time to pause and figure out how best to individualize care is that we do have an opportunity to try to assess. I said the patient's preferences here. In many ways, it's really who the patient is in front of us. Right? One of the challenging parts about cardiac arrest care is you don't have the chance to figure out the details that can make a difference in making these kinds of determinations. But when a lot of these unfavorable features are present, you're going to take some time to gather more data. One of the important kinds of data to gather are the things that can help to figure out who that patient is. Sometimes that's as simple as questions about whether or not there are advanced directives that exist. Sometimes it does offer an opportunity to get in touch with a surrogate who may be able to provide some insights about that patient's functional status, that patient's values. And most importantly, on our part, we have an obligation to have direct and honest communication with decision makers about the potential kinds of outcomes that we're facing with the choices that we have to make. So I'll turn this over to Michael, who's going to talk about this.
All right, so we'll try to finish up here and then maybe leave some time for discussion. One thing I do want to just make note of is that when you look at the unfavorable features, one of the things that's not listed in the unfavorable features is the neurologic exam. And so we're trying to do a lot of assessments to figure out what the neurologic prognosis of a patient is in an emergency situation and make a snap decision. And one of the things that's not helpful in the literature is the neurologic exam. And so the fact that the patient's comatose, has fixed and dilated pupils, is not moving, is not communicating, or maybe even having some jerks does not mean that neurologic outcomes are futile. So I just wanted to make that statement, is that there's a lot of ways to try to predict risk and predict neurologic recovery, but the exam in the acute setting is not necessarily one of those. And then the final point on the talk is about some of our quality programs, such as public reporting and pay for performance as it relates to total PCI mortality, and try to ask a specific question: are these quality initiatives improving or worsening the quality of care for our patients with cardiac arrest? And as we all know, that there is increasing transparency in the world. We're in a new era of healthcare delivery, and a lot of our outcomes are going to be both reported and collected. And one of the things that, for those who may not be involved in PCI, may not know is that PCI total mortality has been endorsed for public reporting. Probably in the near term will be on websites such as hospitalcompare.gov, perhaps physiciancompare.gov. And in addition to probably being, and there's actually states out there that are already doing this and publicly reporting data such as PCI mortality. And in addition to public reporting, there are other ways of incentivizing high or improved PCI mortality, and that's through pay for performance initiatives. And those are currently ongoing with such things such as QHIP today. And so the question is does this meet the American College of Cardiology's foundation principles for public reporting? And I want to just bring up two that they feel that really raise to the top of the list. That the driving force behind physician performance measurement and reporting systems should be to promote quality improvement. Makes sense. And then two, public reporting programs should be based on measures with scientific validity. And the question is as it relates to the cardiac arrest population and some of our really sick PCI patients, does this hold true? And the reason that there's a question is that there's an outsized mortality in our patients with cardiac arrest. That if you look at their NCDR, in-hospital mortality, millions of PCIs, that those with cardiac arrest and shock, or salvage PCI, or cardiac arrest in general, have much higher mortalities than those with our emergency procedures, or in particular our elective PCI procedures. So the question is do hospitals that take on more of these patients, or do operators that take on more of these patients, are they going to be penalized by having higher mortality? Now, we should say that this is risk-adjusted mortality and not total mortality, and I don't want to get into a discussion of whether risk adjustment is adequate. I think that's a different discussion for a different day. Whether a 13-variable model can pick up the complexities of these patients and whether 13 variables is adequate to really adequately risk adjust is not really important, because what is important is what physicians think, because that's going to be what influences the behavior. And I think it's pretty clear what physicians think, and physicians do not trust risk adjustment. This is data from New York where they've interviewed the cardiologists and said, what do you think? Do you agree or disagree that models are sufficient to avoid penalizing physicians who perform higher risk interventions? And it's quite clear that they disagree with that. And thus, whether it can be done isn't important. It's not thought that it can be done by the community, thus setting up a potential for risk aversion. So how does this then translate into the outcomes? And what's interesting is that when the public reporting of PCI mortality has not been shown to be beneficial, and actually the data may suggest that it actually leads to harm. There's actually higher ST elevation mortality in states that publicly report their data compared to non-public reported. This is from JAMA looking at Medicare data, so about 50,000 patients from public reporting states compared to a similar amount from non-reporting states. And in the patients with ST elevation, those that have that are in public reporting states have about a 35% adjusted higher mortality compared to the non-reporting states. Now, this is based on Medicare claims data, so it's not robust registry data, and so it's hypothesis generating. It's certainly not confirmatory. The question is why? Why would there be this? And what is, I think, pretty clear is that there's lower utilization of PCI and acute myocardial infarction in public reporting states. Again, from this article, when you look at patients with ST elevation, cardiogenic shock, cardiac arrest, that there's somewhere between a 20-25% lower utilization of PCI in these populations. And this isn't utilization of PCI in a COURAGE population elective where there's some controversy about the benefits. This is about utilization of a therapy that is guideline recommended class 1 with robust data to support its evidence, and yet is being utilized to a lower degree. This graphically shows this same thing. Here's all the 50 states, and then look at New York, Massachusetts, Pennsylvania, some of these states that publicly report. They have the lowest utilization of PCI for cardiac arrest and cardiogenic shock. So a therapy that can be very beneficial, some of the lowest utilization rates in the country for those states that do this. And if there's any question about the causation, it's interesting to follow Massachusetts' story, because it was it changed from a non-reporting state to a reporting state during this study period in this study. So compared to the non-reporting states, Massachusetts had a similar utilization of intervention and PCI for patients with acute myocardial infarction before the public reporting process began. Then after public reporting starts, you can see that Massachusetts had a drop-off in the utilization and use of PCI compared to non-reporting states, at least suggesting that there was a causation, or that the public reporting led to a decreased utilization of what is a guideline recommended care, PCI and acute myocardial infarction. Similar findings were recently seen in a JACC article from nationwide inpatient sample, 80,000 patients. Again, ST elevation MI, cardiac arrest, cardiogenic shock, patients who usually derive benefit from angiography and intervention, somewhere about a 40% lower utilization of these guideline therapies in states with public reporting. And again, similar findings that when you looked at the all-cause mortality in acute myocardial infarction, higher in the public reporting states than. And this is the interesting finding, though, is that it depends upon what you look at. If you look at the procedures that are performed, the mortality is actually lower in the states that publicly report the data. So if you're only looking at the one side of the coin, which is those procedures that are done, then it may look that public reporting is improving outcomes because you actually are having lower mortality. But if you look at the cases that aren't done, the procedures that aren't performed, the patients who don't get PCI with acute MI, they actually have a worse mortality in the public reporting states. Now, this is observational data. This isn't definitive, but it certainly brings up at least a hypothesis that there may be some case selection going on, and when reporting goes on, you're starting to select the patients for the procedures that are going to do worse, and select against patients who would who would not do as well. Again, it's just a hypothesis, and it really asks the question: is does public reporting and pay for performance of at least mortality cause a risk avoidance creep? And if you disincentivize patients who have a low likelihood of survival from the procedure, and incentivize patients who have a high chance of survival from the procedure, then you disincentivize away from patients who could derive a large incremental health benefit but a low likelihood of survival towards procedures that have high chances of survival but low likelihoods of health benefits. So there is at least in theory a risk for the case selection creep that can cause with this. And so when we go back to the goals of why we even think about this, remember the public reporting, pay for performance, the driving force behind this measurement should be to promote quality improvement. And so the question is that happening in the cardiac arrest population? At least it's suggestive that that may not be the case. And the other question is these public reporting should be based on measures with scientific validity. And is it scientifically valid to take patients with cardiogenic shock, cardiac arrest, salvage PCI, and smush them together with elective PCI population that has a very low mortality? And should these patients be looked at differently in total? The other thing that's really important about this whole area is that transparency is good. There is a need to move towards this and empower patients as consumers. But in emergency situations, does that apply? We have patients with cardiac arrest. They're going to be picked up by the EMS. They're going to go to the closest hospital that can take care of them, and they're going to get the physician on call that night. There's not a lot of consumerism going on in the emergency situations. And so it is an issue. It has been thought about, and the American Heart Association thought it was important enough to put a position paper out about the impact of PCI performance reporting on resuscitation centers. It's a nice document, and I will just summarize their summary, which I think makes sense. They say out-of-hospital cardiac arrest should be tracked, but not publicly reported or used for overall PCI performance ranking, which would allow for accountability of their management but would not penalize high-volume cardiac resuscitation centers. I would also say in high-volume cardiac resuscitation operators. And these patients should probably not be included in public reporting. Probably the same thing for pay for performance. And the ST elevation MI guidelines, the STEMI guidelines, actually say the exact same thing. This is a direct quote. It's important for organizations that collect and publicly report STEMI and PCI data to consider resuscitated out-of-hospital cardiac arrest patients separately from their hospital and individual operator quality scorecards, because such patients, even with optimal care, have much higher mortality rate. So this seems to be the goals of the American Heart and our STEMI guidelines, yet tends to be a little bit counter to our current QHIP programs, pay for performance, as well as the public reporting that's been endorsed by the American College of Cardiology and the National Quality Forum. So I think that there's at least some concerns there. Tanveer, do you want to bring some conclusions?
So in conclusion, most patients with out-of-hospital cardiac arrest with return to spontaneous circulation without unfavorable features should undergo targeted temperature management, emergent angiography, culprit lesion PCI, and hemodynamic assessment and support. Patients without STEMI should also undergo urgent angiography. However, consultation with interventional cardiology is warranted prior to cath lab activation. Individualized treatment must be undertaken in patients with multiple unfavorable resuscitation features, understanding that there are no absolute predictors of futility. Patients with out-of-hospital cardiac arrest should be excluded from public reporting and pay for performance metrics. It's important to know that a lot of these public reporting measures in interventional cardiology, decisions about these were made by non-interventionalists. And for the patient who arrives in the ER or the family member who's with them, they really do not care which hospital they arrive. Survival is important. But the data that's been collected is being used by payers to really look over our shoulders and to reward us in means that are not beneficial to the entire citizenry of this country. So what has happened since then, where we've gone since this paper was published, and I'll go to that. We've had a lot of reviews of this paper. We have over 1,700 reviews. The publisher has sent this to us. And what the American College of Cardiology has done now is that there is a committee of the Board of Governors and members of the Interventional Council to address this issue and take it back to the table. And for the interventionists in this room, we have now created survey questions about this, which will come into your mailbox soon, so that the 5,900 interventionists and members of the American College of Cardiology can weigh in on the subject and see what is the best approach to recommend. So we have 3 questions at the end. True, false. 53% of witnessed cardiac arrests receive CPR. False, only 16% do. A pH of 7.2 and lactate of less than 7 millimoles per liter predicts survival. That is true. And finally, significant CAD is found in 29% of patients with out-of-hospital cardiac arrest who do not demonstrate ST elevation of the ECG. I think that number is 58, 29% of acute occlusion. With that, we'll end and we'll leave time for questions.
Well, thank you. For presenting on that very challenging issue. I think we all have sort of memories of great recoveries and disastrous recoveries from these situations, and it's really challenging for all of us when we deal with these patients. I guess for me there were a couple of take-home points, and the one being that demarcation for the non-ST elevation and not activating based on that, and having some recommendations to guide that. The second is just sort of the total dearth of data, as Neal pointed out. I mean, just looking at some of the data you presented, the mortality rates vary dramatically between studies, from 16 to 40%, and survival rates similarly. So it's really hard to make head or tails out of it. So I'll start with, while everyone's queuing up questions, just to remind you, if you're remote, just use that box to chat in, and locally use the microphones. I'll start with Neal, though. So what are the chances of getting a study going, and how will that happen? I mean, because that's obviously going to be a tough one to get going, and I'm assuming this is not a pharma study. This is going to be some big NIH study, and how would you pull that off?
Yeah, so that's a great question. There is, there have been 2 large networks, one funded by NHLBI, one funded by NINDS. The NHLBI funded network has been the Resuscitation Outcomes Consortium, the NINDS, the NET, the Neurologic Emergency Treatment Trials group. Both of these have, I think, demonstrated the capacity to do trials in the context of acute emergencies under the exception from informed consent. You have a collection of sites with growing experience, and a real, if you look at the number of studies done in these contexts over recent years, it has grown. The regulations are about 20 years old facilitating it, and you look, there's sort of a trickle of studies for the first few years. They're starting to grow. People are becoming, IRBs are becoming more comfortable with this idea. EMS folks are becoming more comfortable with the idea, and some of the onerous requirements related to community consultation and other things I think are starting to lift a little bit. Not that the requirements are starting to lift, but the experience is starting to grow, and so the kind of hurdles to doing these from a sort of local site perspective are starting to get lower. The biggest question obviously is sort of figuring out the right question, getting buy-in from providers who are willing to randomize their patients to different kinds of interventions. And I think we have identified a handful of features in this algorithm and other kinds of things which could be the basis for trials like that. I know that Carl Kern was talking about the fact that there is some ongoing efforts to try to appeal to NHLBI in particular about doing a trial of randomizing to emergent activation or emergent angiography in the context of comatose patients with non-STEMI. The other thing I would say is that we've had some interesting examples recently. The TASTE MI trial may be the most I think, the best example of this, of registry-based trials, right? So one interesting question is if we have adequate registry mechanisms in place, the process of randomizing and collecting outcomes can become a lot simpler. So the TASTE MI trial was a trial done on sort of a fraction of the budget of most randomized control trials. It was done in Sweden, I believe, with existing data, and all they did was randomize to thrombus aspiration or not in the context of of STEMI. And so there's some moving, all that to say, there's it's a significant progress with regard to the ability to get trials like this done, and I think there's some exciting prospects for it.
Open up to questions.
So I just want to congratulate the three of you for really taking on a very, very complex area, as Bob said. I think that it's important to realize that some of this particular problem, there's so much variability, not only on the brain side, but the heart side, and when the disease process started, that teasing out risk factors, which would be the first step in organizing a trial, right? You need to figure out who are the highest risk patients. I think you guys did a great first job at it. Obviously, multivariable analysis would be good. It's a matter of collecting the existing data from lots of disparate studies, as Bob mentioned, with different outcomes and stuff. So I think the next step, as you say, should be a standardization before we get into any trial, is standardized care across multiple centers, collecting the data, trying to really predict risk in a multivariable way, and then using that risk to then inform a randomized trial. I will say that last night we were on call and we did get activated for a out-of-hospital cardiac arrest in an 85-year-old lady who, after the activation and all the cath lab team were on their way in, it appeared that she had metastatic cancer, and she was down for more than 30 minutes, and there was obviously no pH, no lactate, etc. So I do think that our profession is in the crosshairs, and a lot more work needs to be done. But even for ST elevation MIs, and after cardiac arrest, I think an interventional consult is the way to go rather than activating those people.
Thanks, Robert Guyton. It's a very nice presentation, guys. The thing that jumps out at me is the fact that we have prospective randomized data that show that in non-STEMI, intervention does not have an incremental benefit if you're awake and talking. And yet we're talking about potentially use of a lot of resources for people who are not awake and talking. There's obviously great selection benefit in the observational trials as to who goes to the cath lab. The healthy people, young, good-looking people are going to go to the cath lab. The decrepit people who are near death are not going to go to the cath lab. And for that reason, I'm a little perplexed that there's such enthusiasm for taking people with non-STEMIs to the cath lab when the incremental benefit in awake talking people has not been demonstrated.
Well, I would say that the real reason, I think the biggest rationale is that the EKG is not a very good predictor of coronary anatomy. And that's the problem is that about a third of this population will have a closed vessel, so which is, I think, by most of our thought process, a STEMI. So it's a STEMI without EKG evidence of a STEMI. And so about a third of this population is the equivalent of a STEMI. We just don't know that they are. The problem is we can't figure out at the time of cath, at the time of before you take them to cath, which of those 3 out of 10 we're talking about. The other thing is that I think that there's other benefits to an early cath strategy that go beyond its revascularization. One is just the diagnosis, two, the rapid assessment of hemodynamics, and the ability to put in support. And so it is a selected group. I'm not saying, and we're not, I mean, I don't want to get up in the middle of the night and do any more casts than I have to, so I don't want to come in for a lot of these cases. But I do think that the data does support in the cardiac arrest out of hospital comatose patients that there's a high incidence of obstructive coronary disease, at least in the observational trials that we do have. There's a high incidence of culprit lesions that are similar to those that you see with a STEMI, and because of those things, we do feel that there's a drive to benefit. The other thing is with non-STEMI, there is a benefit in PCI, so I would say that there's the elective population we can debate. The non-STEMI population, I would say, is pretty sound, that there is morbidity and mortality data for high-risk non-STEMI for revascularization and PCI.
But not for emergent revascularization.
Yes, not emergent, but that's the difference is when you have a non-STEMI, you can go down, that's awake, you can go down and ask the patient about their emergency nature of it. Some of them are emergent, and if you say, patient, are you having chest pain, and they're having chest pain, then they need to go emergently because that's an emergency situation. We don't have the luxury of talking to the patient in the comatose scenario, and so that's the issue. Is that majority won't have a closed vessel, but 3 out of 10 will, and that's the debate we have: is do you cath the majority for the minority, or do you wait?
You're assessing these people.
Just to be real clear about the benefit of PCI, so I think your point is that there may not be documented benefit for emergency PCI, but obviously non-STEMI in general is pretty well, high-risk non-STEMI is well regarded as benefit for PCI. I do think, Mike, though, that Robert is right in that our recommendations, or at least our suggestion, to take the patients with out-of-hospital cardiac arrest without ST elevation MI to the cath lab for angiography has to be tempered, because the arguments you make are good, but they're very observational and preliminary, and I think that's what you're suggesting, is that we really do need more data before making those recommendations.
Completely agree.
So that's not working for some.
So we get hung out sometimes in the individual with an NSTEMI, or the individual having chest discomfort that sounds convincing and does not have ST segment elevation. So in that 29% group there, it would seem to me that you often would find, if you find a coronary lesion, you'd find the circumflex. So you get caught in the emergency room with someone that's got a chest discomfort that sounds impressive, that the ST segments are not up, and they just hang out for a while there when they can have a circumflex occluded every time. We don't seem to kind of emphasize that enough, in my opinion, but that's a culprit vessel. It would seem to me often in that 29%. Would you agree with that or not?
Oh, I completely agree. Yeah, the circumflex, high marginal, high diag, and that's why the non-STEMI guidelines. This is off the topic of cardiac arrest, but the non-STEMI guidelines suggest immediate angiography within 2 hours is indicated for patients with non-STEMI and ongoing chest pain. So and chest pain may be the only marker of ongoing injury. So that is I would agree with that.
But Stephen, these non-STEMIs, you can call Kern's observation, they're predominantly LAD occlusions. They're not circ occlusions, but rather right. So the LAD was a predominant early occluded culprit vessel.
All right. Well, thanks again, guys, for a fantastic presentation.
The preceding program is copyrighted by Emory University.